Ludwigs angina, described by Wilhelm Friedrich von Ludwig. Ludwig's angina is a rapidly spreading cellulitis involving the floor of the mouth. Described in 1836 by Wilhelm Friedrich von Ludwig. This disorder has a potential for airway obstruction. Ludwig's angina primarily involves the submandibular space. The submandibular space can be divided into two, namely the submaxillary and the sublingual space. These two spaces are separated from each other by the mylohyoid muscle and are connected posteriorly through a cleft, and this is known as the mylohyoid cleft. This shows the mylohyoid muscle at the posterior border of which is the mylohyoid cleft. The mylohyoid cleft contains the following structures: tail of the submandibular gland, Wharton's duct, lingual nerve, hypoglossal nerve, lymphatics, arteries and veins. The floor of the submandibular space is formed by the superficial layer of deep cervical fascia. It is attached from the hyoid bone to the mandible. This space communicates across the midline with that of the space on the opposite side. Boundaries of the submandibular space. The submandibular space is bounded by the oral mucosa and tongue superiorly and medially, the mandible superiorly, the superficial layer of deep cervical fascia with its tight attachment to the mandible and hyoid bone laterally, and the hyoid bone inferiorly. Since the mandible and superficial layer of deep cervical fascia provide unyielding barriers superiorly and laterally, the tongue is forced upward and posteriorly, giving rise to airway obstruction. This is the most important danger in Ludwig's angina. This shows the tongue being pushed upwards and backwards as a result of infection in the submandibular space, and this is a major complication of Ludwig's angina, resulting in airway obstruction. Dental infections are the commonest cause of Ludwig's angina. An important factor to be considered is the relationship of mandibular dentition to the attachment of the mylohyoid muscle. This line of attachment is called the mylohyoid ridge. The anterior teeth and first molars regularly attach superior to this line, and infections arising from these roots commonly result in a limited sublingual abscess. The second and third molar roots are attached routinely below the mylohyoid ridge, and infections involving these roots cause infections of the submaxillary space. One other important relationship is that the roots of the anterior teeth and first molar approximate the lateral mandibular surface, whereas the second and third molar tooth roots approach the lingual surface of the mandible. That shows the mylohyoid ridge, and it is evident here that the roots of the second and third molars are in relationship below the mylohyoid ridge. Criteria for diagnosing Ludwig's angina. following features should be present in order to confirm a diagnosis. Number 1. Rapidly spreading cellulitis with no specific tendency to form abscess. Involvement of both submaxillary and sublingual spaces, usually bilaterally. Spread of direct extension along facial planes and not through lymphatics. Involvement of muscle and fascia but not submandibular gland or lymph nodes. Originates in the submaxillary space with progression to involve the sublingual space and floor of mouth. Etiology. Ludwigs angina is commonly caused as a sequelae to dental infections. It is quite common in young adults with periodontal disease. Dental causes account for nearly 70 to 80% of these cases. Penetrating injuries involving the floor of the mouth, stab wounds, gunshots, etc. and mandibular fractures. Bacteriology of Ludwigs angina. Since the majority of cases of Ludwigs are caused by dental infections, cultures from this infected area usually show oral cavity flora. The most common aerobes isolated are alpha hemolytic streptococci followed by staphylococci. Anaerobic cultures are difficult to interpret. The anaerobes isolated are Peptostreptococcus, Peptococcus, fusiform bacteria, nucleatum, and bacteroids. The combination of aerobic and anaerobic organisms has a synergistic effect due to production of endotoxins like collagenase, hyaluronidase, and proteases. These endotoxins contribute to the rapidly spreading cellulitis. Clinical features. Patients present with increasing oral cavity and neck pain. They have poor oral hygiene. They are at first unilateral but soon become bilateral. The soft tissues of the floor of the mouth swells. The tongue gets pushed posteriorly, causing airway obstruction. These patients are febrile, and on examination they have tachycardia, fever, variable degree of respiratory obstruction with dysphagia and drooling. The submandibular and submental regions are tense, swollen, and tender. The floor of the mouth may become tense, swollen, and indurated. Fluctuation is not present and the tongue is seen to be pushed backwards. Diagnosis. And this is based on clinical features. Patients may show leukocytosis. X-ray soft tissues may show soft tissue edema, and the CT scan is to be considered in all persistent cases to rule out complications. X-ray chest must also be considered to rule out mediastinitis. Management. Airway management. Since the airway is threatened, insertion of oral airway is to be considered. If the patient does not tolerate an oral airway, then tracheostomy is to be considered. Intravenous antibiotics with broad spectrum features, namely chloramphenicol, may be administered. The drug of choice is amoxicillin with clavulanic acid. Metronidazole must also be administered. Clindamycin can be administered in resistant cases. Role of surgical drainage. Wide decompression of the suprahyoid region may be considered. The approach is through a median horizontal incision 3 to 4 finger breadths below the mandibular margin. The mylohyoid muscle is split in the middle. line, and drainage is established both medially and laterally. Pus is rarely encountered, but starts to drain several days after the procedure. Complications: airway compromise, extension to mediastinum causing mediastinitis. This can be suspected if there is persistent swelling in the neck with pain, spiking fever, and persistent leukocytosis. Extension into the carotid sheath and retropharyngeal space. That shows the spread of cellulitis, the tongue being pushed upwards and backwards, compromising airway. We can see the mylohyoid muscle and the sublingual and the submaxillary space. We see the submandibular gland wrapped around the mylohyoid muscle. Again, we note the sublingual and the submaxillary space. To summarize, Ludwigs angina is a bilateral infection of the submandibular space, which consists of two components in the floor of the mouth, namely the sublingual space and the submaxillary space, also called the submylohyoid space, described in 1836 by the German physician Wilhelm Friedrich von Ludwig. This infection most commonly arises from an infected second or third mandibular molar tooth. It is an aggressive, rapidly spreading cellulitis without lymphadenopathy with potential for airway obstruction and requires careful monitoring.